invite Dr. Anuradha to speak on our topic, blinded by aneurysm, sixth nerve palsy, and the silent role of sympathetic paralysis.
May I start, ma'am? Good morning, everyone. I'm Dr. Anuradha, and today I bring to you a case of unilateral sixth cranial nerve palsy, which was unique with respect to its associated features and how a careful clinical examination can help localize the lesion in such cases prior to confirmation by radiology. Abducens palsy is a common presentation in ophthalmology and mostly has microvascular etiology and is painless in nature. A painful palsy should always raise alarms to find out the cause of the same as promptly as possible. In the absence of immediate access to radiology, a careful clinical exam can lead to precise localization of the lesion. My patient was a 58-year-old lady, a known case of hypertension but non-compliant with medication. She presented in accident and emergency with acute onset headache and right ocular pain, along with giddiness and vomiting. There was no history of any other diagnosed systemic ailments of significant past and personal history. On general examination, the patient was tachycardic with blood pressure on the higher side. Central nervous system exam revealed a right-sided abducens palsy with no other focal neurological deficits. Rest of the systemic examination was within normal limits. The patient had initially been evaluated and admitted under internal medicine with a provisional diagnosis of headache with primary hypertension. The differential diagnoses considered as per clinical notes were myasthenia gravis and Tolosa-Hunt syndrome. The patient was managed with analgesics, antihypertensives, drugs for vertigo and steroids, which was essentially symptomatic treatment. An ophthalmological consultation was sought during office hours the next day. Before coming to ophthalmic evaluation, let me please briefly mention that the baseline investigations and investigations for myasthenia gravis and autoimmune disorders were within normal limits. A bilateral carotid Doppler was also within normal limits. On ophthalmic examination, the patient had an aided visual acuity of 6/9 and near acuity of N6 in both eyes. There was an obvious face turn to the right side due to right abducens palsy. There was also a mild ptosis in the right eye. There was esotropia with complaint of diplopia in primary gaze. There was limitation of abduction in the right eye. Anterior segment examination revealed anisocoria in the form of meiosis of the right eye, which was greater in the dark. There was nuclear sclerosis in both eyes, which explained the impairment in vision. Fundus examination was within normal limits in both eyes. So based on presentation and clinical evaluation, we had a patient with painful sixth nerve palsy, along with headache and diplopia, with signal towards a compressive lesion. The mild ptosis was likely due to Muller muscle paralysis. Together, these features suggested a lesion within the cavernous sinus in the internal carotid artery region, possibly an aneurysm or thrombosis, because this is the region where both abducens nerve and sympathetic plexus lie in close proximity. This is in fact a symptom complex known as Parkinson's syndrome that has been reported in literature and is an important method of localization of lesion in such patients. Our diagnosis was confirmed by radiology, which revealed a saccular aneurysm of the internal carotid artery in the right cavernous sinus, as can be seen in plain and contrast-enhanced MRI images of the patient in the axial and sagittal views. Following confirmation of diagnosis, the patient underwent endovascular placement of a flow diverter stent within the cavernous segment of internal carotid artery. This procedure was undertaken in a tertiary care center as the facility for interventional radiology was not available at our center. Following surgery, the patient had an uneventful recovery with gradual resolution of symptoms. This is the post-operative picture of the patient. There is orthophoria in primary gaze with recovery of ocular movements. A residual ptosis, however, has remained. To reiterate, a sudden painful nerve palsy should always be suspected to be due to a compressive lesion, though imaging is crucial in localization of the lesion and even treatment of the case. A casual clinical examination can lead to loss of precious time in ordering the correct radiological investigation. In this case, the initial treatment was targeted toward control of pain and blood pressure and prophylactic steroid. The initial differentials considered were myasthenia gravis and Tolosa-Hunt syndrome, neither of which fits the clinical spectrum of this patient. Parkinson's syndrome is a symptom complex which has been reported in literature but is still not common knowledge. It is essentially the presence of ipsilateral abducens palsy with mild ptosis and no features of other cranial nerve involvement. This suggests the presence of lesion in the cavernous sinus of the internal carotid artery, causing damage to abducens nerve and sympathetic plexus due to close proximity, leading to lateral rectus palsy along with the post-ganglionic Horner syndrome. Identification of such lesions clinically can lead to prompt and effective radiological investigation and management of the patient. To conclude, a painful cranial nerve palsy is a neuro-ophthalmic emergency and should raise the suspicion of a compressive lesion. A careful clinical examination can accurately localize the lesion while awaiting imaging results. Crucial time should not be wasted in symptomatic treatment without concrete evidence, and a high index of suspicion is important in preserving sight and life. This case is an excellent example of how simultaneous multidisciplinary approach can lead to prompt and effective treatment of a potentially life-threatening condition. These are my references.